As an anesthesiologist, Jon Bloom was distressed to participate in so many footy amputations for diabetic patients. He vowed to do something to consign this barbaric Civil War-era procedure to the dustbin of history. Eventually, he met up with some like-minded co-founders at an early hackathon, and the result was Podimetrics. A decade later, the team has developed and deployed a technology and care management solution that is putting this goal in reach. Of course, in the U.S. healthcare system, amputations are lucrative for providers, but prevention is not. So that's an extra hurdle Podimetrics has had to clear. In this episode of the HealthBiz podcast, Jon traces Podimetrics' path, but we also carve out time to discuss high school marching band, why it took him 8 years to graduate from college, his dreams of being a punk rock musician, and what my son Harry was like as a Podimetrics summer intern. I'm your host, David Williams, and I hope you enjoy the show. Meanwhile, if your healthcare or life sciences business needs strategy consulting, I'd be happy to discuss. We have 2 decades of experience working with companies whose strategic opportunities and challenges are similar to Podimetrics. You can reach me at dwilliams@healthbusinessgroup.com. Well, Dr. Jon Bloom, CEO and co-founder of Podimetrics, it is nice to have you with me today.
It's wonderful to be here. Thank you very much.
Listen, we're going to get to the present and the future in no time, but let's wind back the clock. I want to ask you about your upbringing, about your childhood. Don't worry, I'm not a psychiatrist, although there may be some who are listening.
Well, gosh, picture a little asthmatic kid kicking the soccer ball around. That's probably my humble roots. Add in a little bit of karate classes when those movies started to really hit the main stage, and then eventually I become a marching band kid, learning how to bang drums really loudly all over the place. I'm sure I made my parents. I'm sure they loved when I got into drums.
Now that sounds good. Listen, when I was growing up, I remember they had an ad on TV. I think it was June Ree's self-defense, and I'm not going to sing it, but it said, "When you take June Ree's self-defense, then you too can say nobody bothers me." And so now marching band. Okay, so that marching band is very important. I was in the marching band too. I was a trumpet player, and the drums can just do whatever the heck they want, and they just really kind of drive and control things. So it sounds like you got some of your revenge at that point.
Music was huge to me. I thought I was going to be a musician. Yeah, I started playing in punk bands because I thought that was going to be the next wave of amazing music, and metal bands, and I thought that was going to be my deal for a while. But
yeah, well, listen, it's not too late. You still you still got time. So in the marching band, so were you the type of marching band that just like played at halftime at the football games? Did you go around to competitions and stuff?
No, big in competitions.
Yeah.
And in our region, we were undefeated like for 4 years in a row, and then we actually went to nationals one year and we won drums. It was if you can picture it, the band was over like 450 people.
Wow.
Over 10% of the high school was in it. It was a juggernaut of a program, and it was a blast.
No kidding. So where was that? What part of the country?
Poway, California, right outside of San Diego.
Got it. Know it well. Unfortunately, I know it for some infamous reasons lately. But yeah. So my marching band. So I was in DC. So you had good weather where you were, because it's always an issue, with the marching band. So I was in Washington D.C. and we went to the championship. I think there may be more than one national championship, because we went to it was so-called the Grand National Championships, and it was at East Tennessee State University in Johnson City, Tennessee, and they had this mini dome. And it was good because it was covered, but it was the worst acoustically. But you could make a heck of a racket with the drums, I'm sure. So
indoors, it's a dangerous thing. Yeah.
All right. So then right from punk to anesthesia. So more or less of a straight path there, or how did that happen?
I think, first of all, I went to undergrad for 8 years. That's usually people get a couple of degrees out of that program. This is one thing, my BS.
Okay.
And, a lot of it was I was kind of lost for a while. I was trying to find my place. I was working full time to pay my way through undergrad. And really the first half of it was, I was failing out of school or nearing at one point. I was almost going to be homeless. And I just kind of had this moment where, wow, something really has to change. Around that same time, I'd come across that 7 Habits of Highly Effective People. That book kind of blew my mind. And then one day I'm at the 1 Hour Photo Lab. That's where I worked at Costco in San Diego. And one of the people who I had cared for a long time, her husband was a cardiothoracic surgeon. She's like, look, you got to hang with my husband for a night. He'll show you some really cool stuff, and I could tell you'd probably really like it. I did it, kind of did it on a whim, and I was electrified. It was one of the most amazing. Here I was at a spot where like things weren't going right, and I needed something to really like just dig into, and it was just it was an electrifying moment. All those things happened at the same time. Needing mission, hungry for it, and that was it. I was like, okay, I'm going to be a cardiothoracic surgeon. Clearly, I wasn't
Got it.
one, but
Yeah, yeah, yeah.
I
Well,
was
you were
obsessed with it.
you're halfway there. So, so that book, I think, 7 Habits of Highly Effective People. I think the first habit is do first things first. And so they told you like do your freshman year of college first, but then they didn't tell you to do it. Keep doing it 4 times before moving
That's
on
right.
to
That's right.
sophomore
Yeah.
year.
When
Yeah,
you do it well at first, but I built like I just remember I was in the parking lot outside of Costco, and this is when I realized I was almost going to be homeless. It was a really tough time, and
yeah,
that was when I put my first draft of a mission statement together, and I still use it today. It's
yeah.
lasted a bit.
So anesthesia, though, I mean, that's not like surgeon. You're cutting people up. Anesthesia, you're putting them to sleep, which is
Yeah.
needed before you're going to cuts them up. But what's like, why anesthesia? Like, what's the mentality of somebody who wants to go into
Yeah.
anesthesia?
I think it's happened to me a couple times where I know I'm going to want to do something and I come out something else because I have to find it or it finds me sometimes. So for a surgeon, you look at this one little box and you don't really look outside the box. You're in that box, and I would be like, oh well, look what's going on over here, and oh that and the anesthesiologist, we have these, it's a complex system, and you have the heart, cardiac system, the pulmonary, everything's working together, and it's a dynamic system. You muck with one part, it's going to go over here, and there's of course these all these blinky lights. You can already tell that I probably fit in really well in an
Yeah.
environment where I'm taking in lots of data from lots of places, and then making decisions really really quickly. I live for that environment, the people I immediately clicked with, and I came out of anesthesiologist. It was like the first day of anesthesia. I'm like, okay, this is home. I just
So
had
it's
no
kind of like
idea.
so it's kind of like with all those lights and the quick decisions. It's kind of like running the soundboard at one of those punk concerts that you were in before. Same. A guy could have been doing one thing or the other, right?
Yeah, yeah. I was just kind of built like it. For example, not everyone likes to run a code. A code is a very scary time.
Right.
Patients there, but to me, like everything slows down at those moments. It's like high tension, and I really enjoyed, being able to think what's happening here. How are we, everyone in this room? How are we going to get to do it? It was, I just those high stress environments. I don't mind them. I
Good.
seek them out at times.
That's good. And I think that's sort of what somebody wants in their anesthesiologist, not somebody who's going to freak out as soon as their heart rate drops or something like that.
Right.
It's
They
kind
often
of,
say it's like boredom, mostly boredom with a few moments of terror, and that's
yeah,
probably about right.
that's good. I will say, and anesthesia, you have the advantage of people are asleep most of the time if you're doing it right. But I remember being in the emergency room actually with one of my kids at Children's Hospital, and there was somebody who was training, and they came in, and it's like, okay, like I've been through certain things with my kids, whatever, but they come in there, and it's like, when the resident freaks out and goes running out of the room, like you're thinking,
Not a good sign.
this is not good. But it was more her issue that she probably shouldn't have been a emergency room doc at a pediatric hospital rather than my kid who was had something serious, but they're since recovered. So
People, and they end up gravitating to that place that they really
yeah,
do sing, and sometimes it's, not every environment
yeah,
works for
she was
everybody.
on her way. She's probably playing some punk band now. I'll have to go find her, check her
May.
out. Now listen, so that wasn't enough. So you'd had 8 years of undergraduate. How long did you take in med
Thankfully, once I buckled down midway through undergrad, it was more efficient. So it was the
Okay,
typical for a medical school, and
right,
that worked.
but then you were on to more school after that, Sloan School.
Yes.
So that's
Well, no,
different.
I went to internship and then
Oh yeah,
residency, and
right.
then I one of my attendings was the chief medical officer of Covidian. This is at Mass General, and he was. I think I was at this point I was going to go into a fellowship in ICU, but he just kind of, the idea of thinking about building technologies that can help people and creating something new. I think I wanted that art part of music again. Like, gosh, you can
Yeah,
create these new things. He lured me in to be his global medical director out in Boulder, Colorado. That was going to be my quick fellowship in
sure.
tech dev, and then it just took over my life. That was that was a big part. But I realized that I couldn't speak the language that was there. They talk about NPV and like
Yeah,
EBITDA. None of that stuff made any sense. So I ended up coming off the firm, and I actually applied during residency to come to
got it.
Sloan to learn the language, and that brought me there.
Good. All right. So I see it's getting more conventional and more straightforward now from that point
Maybe,
on.
yeah,
Yeah. All right. Well, we got a few more twists and turns. All right. So that
yeah.
brings us up to the present, although it's probably been about 10 years or so since you started Podimetrics. So, what was the story of the founding there? What was the unmet need? Are you a co-founder? Who'd you bring into it? How did it get going?
Well, yeah, gosh, similar to medical training, where I came in knowing I was going to be a surgeon, and I came out an anesthesiologist. Here, I came into Sloan knowing I was going to be a venture capitalist, and I just came out an entrepreneur. That's really how I was built. And there was a weekend event called Hacking Medicine. They'd never done it before. Now Hacking Medicine is like its own
Yeah.
institution out here, but they'd never done it before. And Elliot, a good friend, is like, look, we're going to put only 100 people in a room, and you have a weekend to hack out any company you want. You're going to love it. And I just remember at the time debating, should I do this? Should I hang out with my
Yeah.
girlfriend? I did it on a whim, not knowing that this is going to completely change my life.
Right.
And David Linder is one of my still a wonderful friend of my our chief technology officer. It was his turn to think of a cool idea. He said, diabetic foot ulcers and doesn't make sense. And it was that another one of those electric moments when you heard that. Because now rewind a little bit. I'd be in residency and I'm rotating on Vasco, and you could spend the entire day doing nothing but amputations.
Yeah. Just like in the Civil War, like at Gettysburg or something.
That's exactly it. Oh my God, that's the language I used back then. It's like, why are we still doing Civil War medicine for something that I felt like we shouldn't be doing anymore? I just remember how needless it was. And if you get an amputation, as much as 70% of them are dead in 5 years. This is terrible. Why can't we? Here I came. I'm an anesthesiologist, so sensors and feedback loops are all we do. And then I go to Covidien. I'm running the medical part of their monitoring division. And now he says foot ulcers. I'm like, oh my gosh, this is an
Yeah.
amazing thing. Could we just detect these wounds before they happen, and then maybe we could eliminate amps? Could we just get rid of that whole part? That was my reason for sitting down. And then there were 5 of us at that table: David, myself, and then that was the beginning of the. We didn't know it, but that was going to be the beginning of our company.
Yeah. No, interesting. I mean, it's a shocking thing, diabetic, foot ulcer. And as you think about, what the battlefield was like in the Civil War, I mean, for
Yeah,
anesthesia, they just used, whiskey or whatever was around, and they
and a
used
bite
some.
block.
Right.
Yeah,
So that's come some distance, but the is still doing these amputations, which is crazy. Now,
yeah,
I don't know if you
it's
knew it at
crazy.
the time. Before you went up against it, but already by then there were a whole bunch of companies that had sort of similar ideas about doing something,
Yeah,
and they turned out to
yeah.
run into problems along the way. And I actually remember looking at Podimetrics and thinking, okay, this is interesting, but I know probably at least 5 companies that had tried something similar and hadn't gotten there. So do you also decided you were going to solve? Were you aware that there were other people trying something similar and sort of crashed and burned?
Not yet.
Yeah,
Early on, we were totally like, oh, this is a good problem. We were unaware of the disasters that were still out ahead of us. Things that we could talk about, some of the
yeah,
challenges of this particular thing. But I think what we did very, very well was we just kept trying to uh, ask or try to break down, like, you can't solve diabetes, that's too big. Well,
yeah,
what about amputations? Great. Well, what about amputations? What about foot ulcers? We realized that the real challenge wasn't actually detecting, preventing foot ulcers. It was, how can you build a system that this patient who's overwhelmed by their care, how could you get them to engage with it so frequently that you're going to get the data that you need for very long periods of time? And then suddenly, once we really realized that that was the real problem to solve, then we got to work, and we ended up, actually, because of it, we just got rid of a lot of these like just booby traps that have been tanking companies that gone into the space.
yeah. So let's talk about that. Evolution. It's interesting to hear how up until that point, kind of your education and career, you pivoted a few times. And while it sounds like there's some things that happen as with any company along the way, the kind of the goal that you were going after still remains the goal today, if I understand right. I mean, it sounds like you're still focused on the same issue. It's not that you hadn't identified something important. Is that fair? I'm sure it's more complicated than that, but
I would say, one of the things that is, why are we here? I think that's such an important question for any company. For me, no more amputations. We want to eliminate this from the population. So, we certainly optimized along that path. We wanted, for example, we to do that, you need data, so that somebody can be a big part of it. We need clinical trials and rigorous data to do it. It starts to point you down what you need to do once you have that clarity of the outcome that you want. So it was great that we had that kind of clarity early on, and we're now that we really get to work well with this patient, we're thinking a lot about how we can continue to help this patient. But that idea of eliminating a problem that should never occur is a wonderfully powerful thing to keep you moving even on days that are they can be tough.
So what is the approach? What do you actually do now that you've identified that as a problem?
So what we build is a mat that goes into the patient's home. It's wireless and cordless. It takes about maybe a month worth of charge before you have to plug it in again. And we ask the patient to stand up for just 20 seconds a day, and then that's it. Go on with the rest of your life. That's the extent of the effort that we need for the patient to do. But in that moment, we collect temperature scans of the feet that come to us in a HIPAA compliant and secure fashion. And then we use machine learning to run through these data, looking for these patterns that are suggestive of a developing wound. And we actually, one of our earlier studies, we found that we could detect 97% of these wounds on the bottom of the foot over 5 weeks before they happen, 37 days on average. And that gave us a wonderful jump in time to do something about it. But of course, the old adage at Covidien and all my old mentors were, it's meaningless to track or monitor something unless you have an intervention. You have to do something about it, otherwise don't look for this
Yeah.
data signal. And we knew that if you could just offload, there's a bunch of things that we had to sort of be validated along, with the process. But with a validated approach and a moment in time to do an action, we had a suspicion that we could have a big impact on outcomes. That big study, of course, come a little bit later, but we were at that point.
So the pad, is it, just help me picture it? Is it like a scale that someone would stand on? Is it the same sort of thing, or you're like standing on a welcome mat, or what is it? What is it like physically, and has that changed over time as you
Yeah,
developed
it's
it?
more like a flat welcome mat. It has definitely changed over time as we've had, better UI and the information to report through their mat. But the other piece to the mat, in terms of the patient experience, is that we also have this care layer on top. Nurses that work with us that then partner with the patient, person to person, creating a relationship and helping to drive the changes and outcomes that we need. And I think that's the other key piece to the design of it. A flat mat, this machine learning logic to it, and then the actual care support to work with patients to make change.
And what's the technology that, because I could stand on a mat and it could tell me nothing. So what's in the mat that's going to actually tell you what's going on under the skin?
We're looking for, it's basically a thermal signature that suggests a developing wound is occurring.
That makes sense. All right. That's how you make it. So you got to make it sound more complicated. When you have these high wire acts, they go and they do this for a living, so they could just walk across the wire, but they always have to like teeter a little bit. So you realize, oh, that's hard. If I were up there, I would fall. So anyway, so you stand on the mat, boom, it reads the thermal signature and it says developing wound, get my nurse on it. So
That's right.
so it sounds like you'd understood. And since you weren't coming at this from a technologist standpoint, but rather from the human issue, you knew that there's more to it than just the technology. How do you develop a protocol that's actually going to have the impact that you want, and then how do you actually test that? When you talk about trials, like what kind of trials do you do? How is that set up? What are you trying to establish?
Well, just like we had the advantage of not heavily having to focus on the tech because we had Brian and David on the team. So, we were actually thinking about clinical and business model. These are ferocious engineers that we got to meet in our company, and they're brilliant and talented. And although I thankfully they would never want me. I remember at one point I was the one doing soldering points, and they got me out
Yeah,
of that really hurt. Like,
stand
okay,
back.
we're done
Yeah, yeah,
soldering. But they just made that part, took it off of our plate because they're
nice.
exceptional engineers. Okay, so now we had to figure out. Your question was like on the data we needed.
Yeah.
Here, give me a rescope. Make sure I go in the right direction.
Like, what does a trial look like? I mean, there's clearly there's sort of the technical part of the trial, but when you're talking about working with an individual, who is at risk of developing a diabetic
Yeah.
foot ulcer, how do you actually test something with the patient and see if it's effective?
Yeah. So what I'll say is we actually came across a number of randomized control trials. That's a good way to do it. Patients with the intervention versus those who didn't, to see were there any differences in hard outcomes. And when we first started stumbling across them, it was like the most, another one of these electrifying moments. I remember the first paper I grabbed, and it talked about sort of how you can use temperature for this purpose. I was floored. They prevented 70% of foot ulcers from occurring in the trial. I'd never read anything like that. There's a
Yeah.
problem this big that they did so well. And then I looked up, the company was vaporized. The company didn't even exist anymore. They completely failed because it had terrible engagement, terrible
Yeah.
adherence. That was the beginning of the riddle. Okay, what we really have to do now is solve, would people use it for long periods of time? So that informed trial number one. Could and we could do two things at the same time. Let's see how good are we at detection. That's where we had that 97% detection stat. But what's the adherence? We found that 86% of the patient population used the system at a clinically meaningful level across the roughly maybe 8.5, 9 month trial. So that was the second piece. Is now let's just prove, could we solve that? But that still doesn't solve what are the outcomes with our device. That then says, okay, trial number, there's probably more than three at this point, but
Yeah.
how do you prove outcomes in ours? And in this case, we actually did as part of one of our commercial evaluations with one of the national health plans. They did it as an IRB collected clinical trial. What we found there is we wanted to follow our patients for 1 year. What was the impact of using our system? And we found out results were quite surprising to us, and much stronger than we had anticipated in this trial. We were able to, first of all, we eliminated 71% of amputations, not just foot ulcers, but actual
Yeah.
amputations. We'd eliminated all major amputations, so meaning no one had lost a limb to diabetes. They may have lost a toe or a part of the foot, but they still were able to ambulate and be independent. We eliminated 52% of all cause hospitalizations across the board. There's a lot of interesting thing in that stat, but
Yeah.
maybe I'll get to that later. 40% of all ER visits off the board, 27% of all outpatient visits off the board. It was about $12,000 in savings per patient per year. And that was the result of, now you put the system in, you add in the intervention, and then you study its impact on the healthcare system. It was fairly strong results.
Now, what's happening at the patient level? In other words, what does it feel? I mean, obviously, it's good for a patient if they are able to continue walking and they don't lose a limb or even a toe. But do they get feedback from this? What is a patient's life like with the mat and the support that you have versus without it?
Well, we have that nurse that has a relationship with them, that knows the exact moment to have a conversation with that patient. It's that timeliness that becomes a very, very powerful thing because of the data that we're pulling from their feet. And that's their experience. They're going to be stepping on the mat. No news is good news. That's a good sign. We're going to keep them engaged, let them know, hey, good work. We're doing great. Of course, if there is a challenge, we're coming in early. We can let them know, and then we get a care plan in to prevent the problem from occurring. So that's the experience on their side. And our net promoter, I think the last time we checked, was like I want to say 74.
Yeah.
And to think about that, like a net promoter in this patient population who's
Right.
like usually negative.
Yeah.
When's the last time like an Aetna would call you and you're like super excited your payer
Yeah.
called? That doesn't happen especially for this patient.
Yeah.
But yet we have a wonderful relationship with our patients and a really high net promoter as a result.
And do you find that, so certainly part of it is that you can, with the imaging, you can see something coming before it's there, so that it's easier to deal with the ulcer before it's actually formed.
Big time.
What's the psychological element of the patient stepping on the pad and the mat and having the conversation with the nurse? Do they try to improve other things in their life to please them, or is it a confounding effect, or is it like a positive thing because they're getting a kind of feedback that they're doing a good job, or or do you don't want even not want to even know about that?
You know, we learn a lot in working with this patient. If you looked at that 52% reduction in all-cause hospitalization, what was interesting is less than half of those were diabetic foot hospitalizations. The majority of them weren't.
Yeah.
And the top DRGs that we were preventing were heart failures, COPD exacerbation, myocardial infarction, heart attacks, and stroke. So once you really get to know this patient, the right time to talk to that patient. Suddenly, we're getting insights across the board And we can do a lot of really good work for this patient. For a patient who often doesn't have good access to the healthcare system, the patients that are most vulnerable are the patients that are often underrepresented or minority populations. I don't think the healthcare system has always figured out how to best work with them, but yet our data is really strong in exactly these populations in these regions of the country.
So, you were citing some work with the health plan. I know you've done a lot of work with the VA, various VAs. What are the sort of populations that you're working with, both in terms of type of patients and then, payers, health systems? Who are the kind of the stakeholders that you're dealing with?
Well, we start with who are we going after patient-wise, and it's this vulnerable, complex patient who's typically overwhelmed by their care. Now, by virtue of usually their age, their employment status, this is typically a patient enrolled in Medicare. Well, sometimes you get some Medicaid, or they're a dual, or both. The VA, of course, has a number of these patients, and as we think about who has this patient, you think about the Medicare Advantage plans. We can sell to them, to the VA. What's challenging is that still in Medicare fee-for-service, prevention does not pay. There aren't
No.
codes for prevention. You're actually reducing codes that are used, right? So it still doesn't quite work. So we have to work with those capitated health plans. That way, we can actually, because prevention should exist. It has every reason that
Yeah.
we want it to exist, but unfortunately, it's really only viable in these Medicare Advantage funds and in integrated plans like Kaiser, the VA.
Yeah.
VA, by the way, is a remarkable place to get care. My dad is a veteran, gets his care at the VA. It's
Yeah.
a good place.
My first job in healthcare, I was in high school, and I worked at a VA medical center in Washington D.C. Yeah, when I was
I love
in high
that.
school, I was doing computer programming in mumps on decision tree analysis. Yeah,
That's awesome.
it was quite a place. And so the doctors I was working with were on the GI side, and one of them was a veteran, and he said, yeah, he would get his care there at the VA. It's quite an interesting place, and incidentally, they were doing a lot of the early work on IT systems for hospitals at that very time when I was there, which is in the mid '80s or early '80s. So
They've been leading out the way in a lot of these, like their medical record. And actually, they don't get the credit for some of the innovation that they've done. It's an impressive organization.
now, what happens in terms of where are you? 10 years later, it's about time to be an overnight sensation, right? A lot of these companies you read about that are just like boom, they came out of nowhere. They've actually been at it for 5 or 10 years at this point. So what's kind of the maturity level of the company? Where do you stand now? What's it looking like as you look out into the future?
It's funny, like if you asked me, 10 years ago, 5 years ago, where would we be? I don't think we had any idea what it would look like when you're working on this is a difficult problem, one where
Yeah,
the business model didn't fit in well, like savings. How do you make a company that has savings? The trials can take years to run because you have to follow patients for very long periods of time. So that took us a good time to collect the data we wanted to justify, quantitative, a financial value proposition to these payers. But now that we're here, gosh, we see our systems in the VA across the country. It's an unbelievable thing to see. We see early reports of how well the system are doing in these sites, and it appears to be doing even better than we saw in the Kaiser trial. We're now seeing the national plans start to partner with us to go after their high risk patient populations. It's amazing that we've been here for a long time, but suddenly now we're coming out. And imagine what COVID did for this. Here's our patient who's very vulnerable, and now we're throttling back all their prevention visits. This patient is reliant on preventative care, and we're like behind the eight ball now as we come out of the pandemic because of suboptimal preventative care. So we got really picked up in that ability. Let's get into their homes now. Let's see how they're doing. Let's get a touch point so we reduce ER visits, hospitalizations, and outpatient visits. It's been an exciting time, and gosh, in many ways, I feel like we're just getting started.
yeah. So I was going to ask you about COVID, and it sounds like you've answered because clearly it's kind of been a crazy year that way. But if you've had this
Yeah.
sort of thing that's of course in the home by
Yep.
definition.
Amputations were up tenfold over what they were pre-COVID per a study out of Ohio. I mean, that's an
Wow.
order of magnitude more, and it's in vulnerable patient populations that are overrepresented in those
Yeah.
amputations.
Yeah.
It's devastating.
So, so you have the mat, you have the solutions around that with the nurses, Any other kind of extensions in terms of the technology or services, or is basically kind of perfecting and honing what you've got? Or is it too
Right
soon to
now,
tell me?
no more amputations. That's what we're looking
Right.
for, is no more amputations.
Yeah.
Come on, we'll talk a little later. I can
Yeah. Yeah.
share some
Yeah.
of this stuff up
All
our
right.
sleeve.
That's fun. Now, John, the reason I heard about you in the first place is because my oldest son actually had an internship with you a few years back when he
Harry,
was in
yes.
college. Yeah, my son Harry, and he asked me about this. He's asks his dad at least occasionally about things, and it says I'm in the healthcare field, and I'm like, my first thought was, there's a lot of companies to earlier conversation, a lot of this big problem. So it's a real problem. It's a legitimate thing to work on, not something frivolous like some other things that people do. But there's a bunch of companies like that really haven't worked out. But then I checked with some of the people that I knew that had run some of those companies. They said, these guys actually have something that's going to work. So I gave them my blessing. So I don't know if it was a blessing or not for Podimetrics, but how was he okay as an intern?
Well, so if he ever thinks to do reference calls and puts me or one of us on, this is basically what we would say. So you get a sort of free shot at it.
All right.
Yeah, he was really talented. A couple of things. He was really resourceful. Even on whatever the budget you would have, what he would make of what he had. He's a great problem solver. And in those parts, I think now that starts to set him up as a really strong engineer, and those when you start to put those two together. But that wasn't my early draw to him. It's funny, we give people technical challenges and they come in, they're presenting, and he hasn't hired yet.
Yeah.
And you put him up in front of a room. Here's what I want to see. I want to see it's their meeting now. I want them to take that meeting, drive it. You're teaching us. Like, we're just sitting in there. It's a kind of intimidating. We're a panel. We're all in there. We're
Yeah.
looking to see where's the what he took command of that room. And he didn't strike me as an engineer in that way. Not that engineers can't be like a leader like that, but he was leading that discussion. So I actually think if he would want to do it, he would be a ferocious entrepreneur, problem solving, resourceful, and yet has that ability to stand up and sort of like with vision and conviction share what he's thinking. It was he was a whirlwind. So I'm glad we were able to steal him in, and I'm sure he's going to do really well wherever he goes.
No, that's good. Well, John, we'll hope that last section stays in the interview, because his sister is my producer. So they actually get along pretty well, but she might cut that out or shape some of your words in a certain way. But thank you. That's nice that's good to hear. So last question is really about, what are you reading? And I can imagine you guys, sounds like all sorts of interests in addition to, what you do for work. Any time for reading, and anything you recommend, if so?
Sure. So some of the books may be more interesting to some people than others. Like, for example, I've been reading Meathead, which is a treatise on proper barbecuing. So that's been fun. Slowly finishing up Leviathan Wakes, which I'm a little bit late to, the whole Expanse. He's an amazing science fiction writer. I'm almost done with Measure What Matters by John Doerr, about OKRs and sort of Andy Grove's amazing model for setting goals. It's just a brilliant system. And then probably prior to that was I reread Good to Great.
Yeah.
This book, I read it 10 years, a long time ago, and it electrified me then. It's kind of dated now in some ways. It's funny. They talk about how Circuit City may be one of the greatest companies on the planet. Of course, they don't even exist anymore. But it's brilliant when you think about, Hedgehog. It's actually a remarkable book when you can come back to it. I probably have other ones. Horowitz had an amazing book on culture. Those are the books of the last maybe a few months. But
no, that's good.
Books.
That's good if you can keep doing that. And now, so do you get into is punk rock like completely behind you, or do you have any?
No.
Yeah.
I was just playing some Bad Brains earlier today.
Nice.
Once it gets in the blood, you can't shake it. And even though I'm sure my wife would really, really like me to shake it, but it's beautiful music.
Have you heard of headphones? I mean,
Verizon, it was fun to wear.
Yeah.
I want to share my love of music.
No, it's good. Yeah. I'm sure she appreciates it in her own way. Well, good. Well, Dr. Jon Bloom, CEO and co-founder of Podimetrics, I want to say thank you very much for being on the HealthBiz podcast today.
Thank you, sir. I really appreciated the opportunity to chat with you.
You've been listening to the HealthBiz podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.